Hello, and thank you for joining this targeted oncology presentation titled Expanding Options for Relapsed Refractory Gastrointestinal Stromal Tumors. Over the past 2 decades, the treatment of GIST with tyrosine kinase inhibitors has improved patients' prognosis and outcomes. However, a percentage of patients present without an identifiable mutation, and others will relapse after 1 or multiple lines of therapy. Today, we're going to talk about a novel approach to treatment for these patients that received FDA approval for treatment of advanced GIST in mid-May of 2020. I'm Dr. Andrew Wagner, Medical Director of Ambulatory Oncology at Dana-Farber Cancer Institute and Associate Professor of Medicine at Harvard Medical School. Joining me today is Dr. Shreyas Kumar Patel, Medical Director of the Sarcoma Center and a tenured Professor of Medicine at the University of Texas MD Anderson Cancer Center in Houston. Thank you so much for joining us. So let's begin. Hi, Shreyas, how are you? Could you start perhaps by describing gastrointestinal stromal tumor and some of the challenges associated with its management? And in particular, how many people are diagnosed with GIST each year? What are the risk factors for it? Frequent symptoms and the stage of diagnosis and effect on prognosis.
Well, thank you, Andy. Most of the audience in this day and age, I think, is aware of the diagnosis of gastrointestinal stromal tumor, but a bit of historical perspective would be, in the dark ages, there was this tumor that we used to call gastrointestinal leiomyosarcomas. It got redefined towards the late 90s into gastrointestinal stromal tumor. Because this is a relatively newer entity, I think the true incidence is a little bit debatable, but the best estimates that we have tell us that in the United States, at least, we have somewhere between 5,000 to 6,000 new cases. A few tidbits to remember: it's called gastrointestinal stromal tumor, implying that the vast majority of these tumors originate from the gastrointestinal tract. But from an embryologic standpoint, the same cells that give rise to the gut give rise to some of the other intra-abdominal structures. So there is this tongue twister diagnosis of extragastrointestinal stromal tumor that could occasionally be arising from the omentum or the peritoneum. Most common sites or locations happen to be stomach, followed by small bowel, followed by a variety of other locations. The very upper and the very lower end of the gut happen to be relatively infrequent. The presenting symptoms, again, are very dependent on the site of origin and obviously the bulk of the tumor. So a typical gastric tumor that's large and eroding the mucosal lining is going to cause some GI bleeds. So a young, otherwise healthy person presents with a near syncopal episode or some dizziness to the emergency room, is found to have a hemoglobin of 5.8, let's say, for example, and a workup that eventually reveals that there is a large abdominal mass with or without other areas of involvement. The typical metastatic pattern tends to be to peritoneum, liver, bone, and then very rarely in the later stages of the disease, it can go to lungs and other parts of the body.
Can you discuss a little bit about the location of gastrointestinal stromal tumor and how that affects diagnosis and prognosis? And what's the likelihood of developing metastases? And are there prognostic features that help us understand that risk?
Good question. I think it'd be important for us to remind our audience that this does fall in this family of tumors that we call soft tissue sarcomas. So some of the same prognostic factors apply. The grade of the tumor reflected here, specifically in gastrointestinal stromal tumors as mitotic activity, is of probably the most prognostic significance. The location of the tumor and the clinical site also happens to be prognostic, where stomach appears to be a more favorable site compared to small bowel and other sites. In terms of predicting the risk of recurrence, there are several different risk assessment models that are out there. The pure clinical ones take into account the size of the tumor, the location of the tumor, and the mitotic activity. Added to that could be some other prognostic factors like, was there a rupture at the time of surgical operation, for example? Mutational analysis, as we will come back to a little bit later, seems to be predictive, but not as much prognostic in terms of what the overall outcomes tend to be.